everyone to discuss an interesting case of persistent leukocytosis in newborn. This was actually a premature newborn whom we evaluated initially for sepsis, and subsequently we went ahead to diagnose a rare case of persistent leukocytosis. So Dr. Adyasha will take you through the clinical presentation and the theory behind it. Hope you'll enjoy it. Dr. Adyasha, over to you now. I request everyone to stay muted and
Yes, sir. Good evening, everyone. I, Dr. Adyasha Kanungo, neonatology resident from NICE Hospital, under the moderation of Dr. Vinay V. Kulkarni, HOD and Senior Consultant, NICE Hospital for Women and Children, Hyderabad, is going to present a case of an extreme preterm baby who presented with persistent leukocytosis since birth and how we went about evaluating the case. To begin with, baby of Mrs. X, an extreme preterm male baby, was born to a couple with second-degree consanguinity at 26 weeks of gestational age on 14th of June 2025 at 9:55 a.m. with birth weight of 700 grams. Baby was born to a 25-year-old preemie mother and was a product of IVF fertilization. There was history of bleeding per vaginal, for which cervical circlage was done. At 23 weeks, serologies were normal, antenatal scans were normal. Baby was born at outside hospital via preterm vaginal delivery. As per the resuscitating doctor, baby was limp at birth, required positive pressure ventilation and intubation at newborn care corner, and was admitted in NICU and started on SIMV mode of ventilation. There, baby was given 2 doses of surfactant, continued on mechanical ventilation and inotropic support for 10 days, later switched to non-invasive ventilation, started on orogastric feeds but kept NBM in view of feed intolerance. Pericardiocentesis was done in view of pericardial effusion, diagnosed with PDA for which paracetamol was given, and PRBC transfusion was done for anemia. On day of life 20, baby was retrieved by a team in view of persistent respiratory distress, sepsis, and preterm care and was shifted to NICU.
क्लास की नहीं है
Sorry?
उठ के जाए छे कि नहीं खाए
Baby was upgraded to SIMV mode of ventilation in view of recurrent apneas, later to HFOV in view of persistent respiratory acidosis. High leukocyte count and chest X-ray was suggestive of pneumonia, ET secretion positive for Klebsiella pneumonia requiring third-line IV antibiotics. Fluid restriction and optimal nutrition was given due to prolonged need of ventilation and chest X-ray showing BPD changes, despite which baby had significant anuria, gross anasarca, and worsening sepsis, requiring peritoneal dialysis for about 16 days and IV pentaglobulin. As baby was period dependent, peritoneal fluid analysis was done, which was suggestive of peritonitis, and Stark aureus growth was noted. Baby required multiple LRBC transfusion. There was extensive perianal rash present instead of optimal treatment. And in view of multiple transfusion and prolonged need of respiratory support, CMV, IgM done was positive and baby was started on Valgan cyclovir. Ultrasound scrotal done showed right hydrocele and left congenital hernia with bowel loops and its content with no signs of obstruction. Ultrasound abdomen done showed multiple splenic abscesses with single posterior abscess measuring around 1.7 mm adjacent to the kidney. Pediatric surgeon opinion was sought and USG guided needle aspiration and drainage was done. Repeat ultrasound was also suggestive of persistent multiple small areas, could be splenic abscess and infarcts.
संजयची मुलगी पालीला एवढी भीती त्यांनी घरात तिथली डुप्लिकेट पाल आणून ठेवलेली टाकायचं भेकड होतात लेकर मग
there will be a facility to mute everyone from your admin app. Please do that.
Okay, sir, I'll do that.
You mute everyone and then continue.
मी इथं बसल्या बसल्या एका मुलाला 15 मिनिटं त्याची मुलाखत घेतली. 8वीचा पोरगा चिंचवडला जाऊन एका फुटबॉल अकॅडमी मध्ये रोज 2 तास तिथं प्रॅक्टिस करून येतो. असा फिट एवढी बिट्टू.
Sorry for the interruption. The bedside ultrasound was done. Ultrasound guided splenic abscess aspiration and drainage was done. Here we can see the ultrasound guided splenic abscesses for which the abscess and drainage was done. And even repeat ultrasound showed collection small cystic areas in the spleen even after 1 week. So these are the serial investigations since birth showing persistent leukocytosis, which is predominantly neutrophilic. Usually in the acute phase, it will be neutrophilic. Later, it becomes lymphocytic dominant, but here it was unusual. Even after repeat investigations over 2 months of hospital stay and management, it was always predominantly neutrophilic in this case. And this is the peripheral smear showing neutrophilic leukocytosis with toxic granules. If we compare both the peripheral smear, there is persistence of toxic granules even after a month of investigation and treatment. So this was done on 24th of July 2025, where we could see the toxic granule, which even persisted after a month repeat of investigation. The persistence of granules was there. So the triggering point in this case are persistent leukocytosis since birth, sepsis not responding to multiple and prolonged courses of antibiotics, splenic abscess or infarcts, peripheral smear suggestive of neutrophilic leukocytosis with toxic granules. So now if we see the major causes of neonatal leukocytosis in a newborn, it is neonatal sepsis, transient myeloproliferative disorder, that is TMD, congenital leukemia, and lastly, primary immunodeficiency, that is PID. So when we compare them, you can see all have a typical onset, that is, it presents since birth or within few days of birth. And PID is mostly after neonatal period, but it can also be diagnosed early. Now, looking at the underlying association, we could rule out TMD as no Down syndrome features were seen. And in the total leukocyte count range in case of neonatal sepsis is 20 to 50,000, whereas in case of TMD and congenital leukemia, it is as high as 1 lakh, and in case of PID, it is variable. The points not favoring congenital leukemia in our case was absence of blast in the differential count and no organomegaly. So we were left with two possibilities. One, the neonatal sepsis, but there was poor response to antibiotics, and PID, which we considered walking up for. So as we know, normal neonates' immune system is anatomically complete, but antigenically inexperienced and shows somewhat decreased role of a number of immunological pathways. Aside from the anatomic characteristics of newborn, weakened pro-inflammatory and T helper cells along with type 1 cytokine release and lessened cell-mediated immunity predispose the neonate more susceptible to all types of infection. So recognizing microorganisms and other foreign material, discriminating it from self and mounting an appropriate response for eliminating it from the body is immunity. So it is of two types. One is innate immunity, the other is adaptive immunity. So innate immunity, natural or native immunity, it refers to intrinsic mechanisms that are poised to react immediately, thus constitute the first line of defense. The major components of the innate immunity are epithelial barriers, which block the entry of microbes, phagocytic cells, that is neutrophils and macrophages, dendritic cells, natural killer cells, and other innate lymphoid cells, plasma proteins, including the proteins of the complement system. In adaptive immunity, acquired or specific immunity, mechanisms that are stimulated by exposure to the microbes and other foreign substances. It includes lymphocytes and their products, including antibodies. So the classification, as we discussed, immune system comprising of innate and adaptive immunity. Now, inborn error of this immunity is what we call as primary immunodeficiency. So primary immunodeficiency are the diseases that are caused by genetic defects that affect the defense mechanism of innate or adaptive immunity, leading to increased susceptibility to infections, autoimmunity, and malignancies. They are a heterogeneous group of conditions with majority of cases presenting in infancy or early childhood, unlike conditions like common variable immunodeficiency that present in late childhood. Neonatal immune system is immature, making early recognition challenging. And secondary immunodeficiency, it is acquired immunodeficiency after birth or as a result of any infections like prematurity, HIV infection following measles, severe malnutrition, nephrotic syndrome, lymphoreticular malignancies, irradiation and chemotherapy for cancer, severe burns, immunosuppressive drugs like glucocorticoid, cyclophosphamide, azathioprine, severe or chronic infections. So now we classify PID. It is combined T and B cell immunodeficiency, predominantly antibody deficiency, phagocytic defects, complement deficiency, and other well-known syndromes like DJOS syndrome. So under T cell disorders, we have severe combined immunodeficiency, which is KID, Wiskott-Aldrich syndrome, ataxia telangiectasia, DJOS anomaly. Under B cell defects, we have X-linked and autosomal recessive A-gamma globulinemia, CVID, selective IgA deficiency, hyper IgM syndromes. Under phagocytic disorders, we have CGD, LAD, CHS, that is cardiac Higashi syndrome, cyclic neutropenia, and under complement disorders, we have C1q deficiency, factor IHD deficiency, and properdin deficiency. So this image illustrates various PIDs and the points in the hematopoietic stem cell or the myeloid and lymphoid lineages where they cause defect. First is the reticular dysgenesis and SCID. They are defects that occur at the stem cell and lymphoid progenitor cell stages respectively, affecting the development of multiple immune cell types. Reticular dysgenesis affects the entire myeloid and lymphoid cells, whereas SCID is combined absence of T and B cells. Likely, CGD and LAD deficiency are defects in the myeloid lineage like neutrophil and monocyte, affecting the innate immunity. So any defect at the precursor level, more severe the disease, and defect in more mature form of cell is less severe the disease. Here again, X-linked A-gamma globulinemia, common variable hypogammaglobulinemia, and selective immunoglobulin deficiency are defects in the B cell development or function. DJOS and Behr's lymphocyte syndrome are defects related to the T cell development. WAS defect is at the level of mature T and B cells, and X-linked hyper IgM syndrome affects the plasma and memory B cells. So how to assess according to the age of presentation? In case of combined immunodeficiency, usually they'll present in infancy, rarely later in life. In predominant T cell defect, the presentation is early onset, usually 2 to 6 months of age. And in predominant B cell defect, the onset after maternal antibodies diminish, usually after 5 to 7 months, later childhood or adulthood. And in granulocyte defect, there is early onset most frequently. In cytolytic defect, childhood onset generally. And in complement defect, the onset at any age of life can be seen. So the major pattern of organism causing diseases in immunodeficiency, in the B cell defects, it is mostly bacterial and protozoan infection. To some extent, viral infection is also involved. In T cell disorders or combined T and B cell defects, we see all 4 categories like bacterial, viral, fungal, and protozoal infection. In the complement disorders, we see more of bacterial infection. And in the phagocytic disorders, like in our case, we see more of bacterial and fungal infection. So in our case, our baby presented with difficult to treat bacterial and fungal infections for first 1 month. Persistent neutrophilia was seen and persistence of the toxic granulation was seen. So our possible differential diagnosis was leukocyte adhesion defect or chronic granulomatous disease. So here in this table, we can see now first three categories are already ruled out as previously discussed. And among the PIDs, which are mostly associated with neonatal leukocytosis, not favoring factors were no albinism, which rules out CHS, no eczema or eosinophilia, ruling out Job syndrome, normal lymphocytes not favoring SCID, normal platelets ruling out WAS, and the factors favoring in this case was the splenic abscess, low DHR or NBT, and neutrophilia, narrowing down the differentials to CGD and LAD. In our case, CMV was positive, favoring the secondary immunodeficiency, but there was persistent neutrophilia, which was unexplained. So we did the workup for the immunodeficiency. In that, DHR showed neutrophilic oxidative burst being markedly decreased, and NBT test dye reduction was absent. So 1 to 3 DHR had complete agreement with NBT, and the flow cytometry was normal, which ruled out LAD for us. So whole exome sequencing done, heterozygous variant of uncertain significance was identified in the RAN-BP2 gene. So our final diagnosis came to be chronic granulomatous disease. Now coming to the neonatal immune system, it relies on maternal IgG transfer, low IgM and Ig at birth, cellular immunity is relatively immature, and innate immune responses are reduced. So neonatal immune system is immature, making early recognition challenging. Early diagnosis is crucial to prevent life-threatening infections. And the inborn errors or metabolism of PIDs associated with this neonatal leukocytosis are mostly LAD, CGD, CHS, hyper IgE syndrome, and autoinflammatory syndromes, and which we are going to discuss in the subsequent slides. So if we see the specific clinical features by type, for T and B cells, early severe infections with FTT is seen. In antibody deficiency disorders, predominantly bacterial infections is seen. For phagocytic defects, deep-seated abscesses and poor healing, which was seen in our case also, with persistence of splenic abscess and persistence of extensive perianal rash even after interventions were seen. And in complement defects, sepsis with encapsulated organisms is seen. So going according to the classification, first we will start with the granulocyte defect, and that is we'll discuss a little about CGD and LAD. So CGD is defect in the neutrophil oxidative burst and predisposition to infection with catalyst positive microorganisms. It can be X-linked or autosomal recessive inheritance. The clinical manifestations are pneumonia, lymphadenitis, and skin and deep-seated abscess. Staphylococcus aureus and Candida species are the most common organisms. We see elevated platelet counts, CRP and ESR is also raised. NBT dye reduction test and DHR assay assess the oxidative potential of neutrophils, as we saw in our workup. As DHR assay is a flow cytometry based test that is more sensitive than the traditional NBT test. This is currently the screening test of choice for CGD. So this is the schematic representation of normal phagocytic function in the differentiation of the myeloid lineage. Neutrophils develop in the bone marrow. Banned neutrophils are released into circulation, and subsequently they travel to the tissues and organs to fight infections using various mechanisms, including phagocytosis, production of reactive oxygen species, and release of antimicrobial peptides to destroy the pathogens. CGD is caused by the impaired phagocytic function of the innate immune system cells owing to mutations in genes encoding the 5 subunits of the NADPH oxidase enzyme complex. The normal respiratory burst process is critical in killing the pathogens, manifesting as CGD when it is dysfunctional. So here is a case report of symptomatic CGD in newborns showing recurrent and severe infection complications affecting the skin. So if we see the first 2 pictures, it is papulo-pustular lesions on an erythematous base on the feet caused due to the severe infections complications in the skin. And the third image is scattered papules with central vesicles on the body in a newborn with CGD. Another case report of an uncommon feature of CGD in a neonate where a 24-day-old boy presented with a diffuse purulent vesicular-pustular rash and multiple osteomyelitis and dactylitis in the foot was seen. NBT and DHR tests were performed for confirming the diagnosis, and osteomyelitis of the left ankle, right elbow, right wrist was seen in technetium 99M whole body scan. So now coming to LAD, it is a rare autosomal recessive primary immunodeficiency disorder characterized by the absence or deficiency of the adhesion molecules, resulting in neutrophils' inability to migrate from the blood vessels, allowing various organisms to attack the tissues. So it is of three types. First is LAD1, where in LAD1, mutation of gene on chromosome 21q22.3 encoding CD18, the leukocyte transmembrane integrin subunit is seen. It is of autosomal recessive type, and absence of CD11 or CD18 surface adhesive glycoproteins on the leukocyte membranes is seen most commonly arising from failure to express the CD18 messenger RNA. There is decreased binding of C3b1 to neutrophils and impaired adhesion to ICAM1 and ICAM2. Here, neutrophilia, recurrent bacterial infection associated with a lack of pus formation is seen, and pathogens, mostly Staphylococcus aureus and enteric gram-negative organism is noted. So here we see multiple ulceration in a 2-month-old infant. First image shows axillary ulcer with necrotic base. Second image shows poor umbilical healing, that is 40 days after the umbilical cord separation. And the last two images is showing multiple groin and thigh ulcers. In LAD2, it is again autosomal recessive type. There is loss of fucosylation of ligands for selectins and other glycol conjugates arising from mutations of the GDP fucus transporter. There is decreased adhesion to activated endothelium expressing ELAM. There is neutrophilia again with recurrent bacterial infection without pus. So this defective mucosylation results in growth retardation and a coarse face. There is long lashes seen, a broad and depressed nasal bridge, simian crease, and dorsally positioned second toes are the clinical stigmata of a patient with LAD type 2. LAD type 3 is again autosomal recessive type. There is impaired integrin function arising from mutations of FERMT3, which encodes kindlin 3 in hematopoietic cells. There is impaired neutrophil adhesion and platelet activation. Again, neutrophilia, recurrent infections, and bleeding tendency are seen. So here we can see in a baby, there is recurrent skin infections in the first two images. There is post-varicella, extensive skin secondary bacterial infection with poor wound healing and characteristic absence of pus is noted. In subsequent images, we can see recurrent ear infections with complications of CSOM, like bilateral CSOM with necrotizing otitis externa and with periauricular abscess with recurrent bleeding from the ear, and right-sided facial palsy is noted. So this is an image of a post-varicella lesion healed with extensive scarring, and the CT of brain is showing erosion of anterior and inferior wall of right external auditory canal with air foci in the right temporomandibular joint. Next is Chediak-Higashi syndrome or CHS. It is again an autosomal recessive disorder. There is easy bruising, oculocutaneous albinism, and recurrent pyogenic infections. Defect is a mutation in the LIST or CHS1 gene. This gene is responsible for the regulation of lysosomal trafficking and the synthesis, fusion, and transport of the cytoplasmic granules. So presence of abnormally large intracytoplasmic granules, especially in the white blood cells and bone marrow, is diagnostic. So here we can see first image is a child presenting with patchy areas of skin hyperpigmentation. Second is a severe form of infection of Staph aureus infection. Third, peripheral smear showing giant granules. And the last image is of bone marrow aspirate showing characteristic giant cytoplasmic granules. Next is hyper IgE syndrome or Job syndrome. It is a rare form of PID. There is recurrent eczema, skin abscesses, pneumonia, eosinophilia, and high serum levels of IgE. And the two most common forms result from variants in STAT3 and DOC8. Diagnosis of the hyper IgE syndrome can be made based on a combination of clinical and laboratory findings for both autosomal dominant and recessive forms. This elevated level of serum IgE levels is a virtually universal finding in these individuals, along with eosinophilia and lymphoma. So we can see the newborn rash of hyper IgE syndrome. It began on the face of this 5-day-old infant and progressed to involve most of the body by 14 days of life. Here we can see diffuse erythematous scaly patches with excoriations and hemorrhagic crusting. Next, most commonly predominant T cell defects which we see in the newborn period. First is severe combined immunodeficiency, that is SCID. Most severe form of immunodeficiency often presents within the first 6 months of life with serious bacterial, viral, and fungal infections. Pneumonia, otitis media, persistent diarrhea, sepsis, oral thrush, and meningitis are the common presenting clinical manifestations. Autosomal recessive and X-linked pattern of inheritance is seen. So this is the bubble boy, most commonly refers to David Vetter, an American boy born with SCID. He lived in a sterile plastic bubble from birth to protect him from life-threatening infections. Here, the absent tonsils can be a key indicator for SCID and X-linked A-gamma globulinemia. This is Omen syndrome. It is a subtype of SCID characterized by persistence of activated and abnormal T lymphocytes in the circulation that infiltrate various tissues such as skin, bone marrow, GI tract, and liver. A scaly erythematous rash with acquired alopecia is a frequent clinical presentation in Omen syndrome. Now, another subtype of SCID is Hoyerl-Reduction syndrome, where mutations in genes telomere biology is seen. Severe variant of dyskeratosis congenita, and the features are IUGR, immunodeficiency, cerebellar hypoplasia, and microcephaly. This is the post-vaccination disseminated BCG or varicella autoimmunity. Now, Wiskott-Aldrich syndrome, again, this is X-linked. Triad is eczema, thrombocytopenia, and immunodeficiency. Bleeding can occur in more than 80%. Triad is eczema, thrombocytopenia, and immunodeficiency. Bleeding can occur in more than 80% of cases. Life-threatening is approximately 30%. Intracranial bleeding occurs only in 2% cases. 40% of these cases can present with autoimmune hemolytic anemia, skin vasculitis, neutropenia, IgA nephropathy, and chronic arthritis. So if a male child presenting with eczematous dermatitis is seen, we can suspect WAS. There is bleeding manifestations, petechiae, purpura, bloody diarrhea, and recurrent infections. Eczema usually appears early in life, and there is increased risk of malignancy in these cases. Now, coming to the predominant B cell defect, usually after 5 to 7 months later childhood to adulthood they'll present, so we don't see cases much in newborn period. Same with cytolytic defect, again the childhood onset. Then comes the complement defect. It can present in any age. In newborn period, we found a case which is linear disease. There was severe generalized seborrheic-like dermatitis along with persistent diarrhea, malabsorption, failure to thrive, and recurrent infections due to the deficiency or dysfunction in complement protein C5. Now, what is this physiologic hypogammaglobulinemia of infancy, which is PHI? There is maternal transferred IgG is existent at birth and disappears over several months with a steady maturation of B cells to plasma cells able to synthesize the immunoglobulins in the newborn. This may lead to PHI with serum IgG levels less than 400, and it lasts for about 3 to 6 months of age. In premature newborns, this PHI will occur earlier, it will be more intense, and it persists longer. So this image is a pair of graphs which will illustrating the changes in the plasma IgG levels in the newborns over time, comparing a full-term gestation with a preterm gestation. So graph A, which is a full-term gestation, it shows that maternal IgG is high at birth due to transplacental transfer. then decreases as the infant's own production of IgG begins. The total IgG level reaches a physiological nadir, that is the lowest point around 3 to 6 months of age, before infant's own production increases and overtakes the maternal IgG. In graph B, it is preterm gestation, which shows a similar pattern, but with a lower initial level of maternal IgG at birth because transplacental transfer is incomplete and the physiologic nadir is reached earlier and more profound, making preterm infant more susceptible to infections. In premature newborns, this PHI occurs earlier, more intense, and it persists longer. Both graphs are also showing the IgM and IgA production produced by the fetus and neonates. So to summarize all, if you approach to a child with suspected PID, first we should see the clinical history, that is the age of presentation. If we have a less than 6 months of age with recurrent serious infections, we should think of SCID or neutrophilic disorders. If more than 6 months of age with recurrent or serious infections, we should think of X-linked hypogammaglobulinemia. Presenting in the second decade of life, it is mostly CVID. Then the clinical presentations, which is the key clues, we should see for syndromic look, recurrent or severe infections, failure to thrive, chronic diarrhea, abdominal distension, lymphadenopathy or organomegaly, lung or cardiac problems, mucosal diseases like thrush, mouth ulcers, skin ulcerations, bleeding, petechiae, poor wound healing or delayed cord separation, adverse reaction to the live vaccines, and positive family history of early infant deaths. Then the type of infection. If it's a viral, fungal, bacterial within few weeks of birth, we can likely immunodeficiency could be SCID. If recurrent pyogenic bacterial infections is seen at late childhood, it could be CVID. If a cryptosporidiosis is seen in early childhood, it can again be SCID. If recurrent staphylococcal, cold abscess and respiratory infection, particularly pneumococci is seen, it is hyper IgE syndrome. In recurrent staph infections or persistent fungal pneumonia, recurrent multiple liver abscesses seen, like in our case, we should think of likely immunodeficiency could be CGD. Now the initial investigation. If we see hemolytic anemia, again CVID, lymphopenia, cell-mediated immunodeficiency, neutropenia, agranulocytosis, polymorphonuclear leukocytosis, think of CGD and LAD, thrombocytopenia, Biscuit-Aldrich syndrome. If the peripheral smear is showing giant granules in neutrophils, CHS is most likely. If chest X-ray is showing persistent pneumonia, CGD, and absent thymic shadow in case of SCID. Again, T and B cell markers, if it is absent or low, it could be in SCID. Absent B cells are seen in XLH. Again, we should also see for the immunoglobulin levels, complement activity as well. Then the newborn screening. T cell receptor excision circles and kappa deleting recombination excision circles, testing from a dried blood spot measures the T and B cell development. If there's low or absent levels, it can indicate severe T cell lymphopenia or SCID. So we should, again, after this, we can go for advanced investigations, genetic testing for PID mutations, specific functional access if needed, and bone marrow studies if indicated. So the red flags for PID is infections with unusual organism, persistent thrush or oral ulcers, severe eczema or autoimmune manifestation, no lymphoid tissue like absent tonsils, persistent neutrophilia, lymphocytosis, lymphopenia, and CBC. So a differential diagnosis is, it can be secondary immunodeficiency like in sepsis, malnutrition, and prematurity, transient hypogammaglobulinemia of infancy, congenital infections, example torch. Management is the early identification and isolation, aggressive treatment of infections, IVIG replacement if needed, if indicated, hematopoietic stem cell transplantation, it is curative in some cases, and genetic counseling. So the key takeaways are high index of suspicion is essential. Simple tests, that is CBC and immunoglobulin levels, can give major clues. Early referral to immunology center improves the outcomes, and newborn screening can detect SCID early. Thank you.
Well, thank you, Adyasha.
Thank you, sir.
I think the presentation was very elaborative and lucid. Overall, I want to summarize that these group of disorders are actually rare, and they are a complete distinct group of disorders which are not generally considered as differentials in the first line in our routine clinical practice. But when we see some unusual patterns, we do have to consider them. And the thing is, the purpose of bringing out this group of disorders in the presentation was that these group of disorders are easily missed, and there are no specific patterns that you can pinpoint. Even in the literature we reviewed for this case related to CGD, different CGDs in newborns are presented in very different ways. No presentation was identical to another one. So it's very unusual to consider it straight away, but we have to take extra high index of suspicion to diagnose such disorders, and we have to go for the designated investigations. Now let's look at the questions. Are there any questions? Reason for pericardial effusion. Yes, the baby presented to us on day 20. Prior to that, there was history of pericardial effusion. We considered two things that might be possibly have led to that. One was the iatrogenic, the migration of the PICC line into the pericardium, which might have led to a pericardial effusion, and subsequently it was drained and the new PICC line was inserted. So other possibility was if that pericardial effusion was born, present at birth, then it could be a part of non-immune hydrops, because babies with such defects usually present with non-immune hydrops. So it was a kind of serous cavity effusion. So which LAD is associated with the Bombay blood group? I think it's LAD2, because that matches with the Cial-Lewis factor 10 in the antigenic mimicry. I don't know. Which are the common differential if admitted newborn has more than 10% eosinophils? I think it's hyper IgE syndrome is one you have to consider. So any more questions? We had 21 participants today. My request is that whenever we conduct such sessions, please mute yourself so that it doesn't disturb the others. We had a couple of interruptions in this session. I think the admin tried to mute them, but it would take time. So if there are no more questions, I would thank Adyasha for the presentation, and I would thank all the participants for their attention. Thank you.
Thank you, sir.